Yeah. Hello, everybody. My colleagues and our junior friends. This is the second program in our PG track session since we started 2 months back. And the first program was very, very successful. And I'm sure this one and the future ones also will be greatly appreciated by the students. And today we'll be discussing about aortoarteritis, a very important topic which is not primarily seen in private hospitals much, but in government hospitals. And occasionally you get patients at any age which turns out to be at the end of the investigations into aortoarteritis because it affects right from brain, coronaries, pulmonary artery, aorta, renal arteries, and everything, the leg arteries also. So we have an eminent speaker today with us. He's a professor of pediatric cardiology from Jaideva Institute. And I would hand over to Dr. Snehal Kulkarni, one of our colleagues and members of the executive committee, to introduce formally Dr. Jai Rangnath. Dr. Snehal, please.
Yeah, thank you, Dr. Kane. It's my pleasure to introduce Dr. Jairangnath, our long-term colleague. He completed his DM in cardiology from Grand Medical College, Mumbai. He received gold medal during his after his DM exam. He did his fellowship in pediatric cardiology from Royal Children's Hospital, Melbourne. Jaideva Hospital in Bangalore is one of the few organizations who has started the official formal training program of DM in pediatric cardiology. And Dr. Jairangnath is the head of pediatric cardiology at Jaideva Hospital. He was a former secretary and now the vice president of Pediatric Cardiac Society of India. His areas of interest is mainly structural interventions, and I think he has done one of the largest number of percutaneous pulmonary wall implantation in India. But has done significant work in aortoarteritis and even juvenile rheumatic mitral valve disease. According to me, one of his very important areas of research is when he tried to look for neonatal pulmonary hypertension, which was secondary to thiamine deficiency. And that was because of the expectant mothers were eating Polish rice, which resulted in thiamine deficiency. And when they gave thiamine to these neonates, the pulmonary hypertension part completely resolved. And actually, that gave a recommendation to the government of Karnataka to give unpolished rice, especially to the expectant mothers, which resulted in complete resolution of neonatal pulmonary hypertension. And I feel, Dr. Jairangnath, this is one of the very big contribution which you have done for the people from Karnataka. And as Dr. Kane said, aortoarteritis is one of the very important area which we, even if we don't see very frequently, but we see one of the patient, we really need to know everything. So thank you, Jairangnath, for accepting our invitation, and we'll be happy to learn you.
So before you start, Dr. Jai Rangnath, I would request Professor Dr. Sharma, who's been our teacher and one of the Bombay doctors who has a lot of experience in aortoarteritis, and they've done a lot of work at KEM, to say a few words before you start, Dr. Jai Rangnath. Dr. Sharma, please go ahead.
Uh, thank you, Dr. Kane, and good evening to everybody. And welcome, Dr. Jairangnath, for being our guest. Uh, before we, before I request Dr. Jairangnath to speak, I wanted to tell few words about aortoarteritis, non-specific aortoarteritis, a disease which was described actually quite a lot. Initial description comes from Mumbai. And there was a monogram which was brought by Dr. P.K. Sen and Dr. Suman Kendre in early 1970s. And this is a very good anecdote I wanted to tell. I joined the department in 78. Dr. P.K. Sen, who used to be a very famous cardiac surgeon, and Dr. Suman Kendre, cardiac pathologist, they have written this monogram. And it was one of the evenings when Dr. P.K. Sen has come to KM. It was a few years after his retirement, and in a party, I was a very young resident at that time. And I asked Dr. Kenre and Dr. P.K. Sen, both were standing. In their monogram, they have written that there is a lot of aortic lymphadenopathy and they postulated that their tuberculosis can be a cause for aortoarteritis. So I inquired from Dr. P.K. Sen that, sir, do you seriously think that this disease is tubercular? And his answer was that I don't think so. It is most likely an autoimmune disease, and we have not been able to find the antigen, and it's for the younger generations to throw more light on this. So, how correct Dr. P.K. Sen was, and how they were apt in their description, and of course, a lot of research in the subsequent years, which we will be listening, has given us a tremendous dimension about this disease. And also, I'll tell a word about Dr. J. Rangnath. Snehal told about his all biodata. I got an opportunity to meet him when he came to Mumbai, uh, to Bombay Hospital, to see Dr. Anil Kumar, who was admitted. And it was COVID time, and I was so surprised. And Anil was so touched to see his gesture that he has come all the way from Bangalore during this COVID period to see his teacher. So I think Dr. J. Rangnath not only has brilliant academic credentials, he has very touching human credentials. So with that, I will request him to give his lecture. Thank you very much.
Good evening, sir. Thank you very much for very nice, kind introduction. Unfortunately, you were retired, sir. When I joined, actually, I retired from Nair. So, though we attended some of your classes, I used to come to Bombay Hospital to attend your classes. Dr. Kaneswar is still in Siam, and I did the DM and Dr. Anil Kumar. He was my favorite teacher. What all I am today is all because of him. He taught me the fundamentals of pediatric cardiology, whatever. I think you all very close friends. I know that. Uh, Let me thank Dr. Kaneswar and Dr. Snehal Kulkarni for inviting me and giving me this opportunity. We all grew up by reading that monogram which you mentioned, sir, P.K. Sen and Kinare's article, that monograms. I think it's around 140 to 150 pages, small book. I must have read about 3 to 4 times before the exams. That too, we knew that our examiner was from Calcutta, Dr. Mantosh Panja. I think they used to do a lot of work at that time. So we must have read it multiple times. So this original work, to start with, it happened in 1960s or 70s. And that time, Dr. P.K. Sen and Dr. Kinare had done a tremendous work. But to tell you frankly, nothing much progress has happened even since then in the form of the etiology. Though the management, we have changed a lot. I am coming to that. My main focus is today the management aspect, which is quite important. Though we have not much done about as far as the etiology is concerned. So let me start going there without wasting my time. So it is a medical management and interventions, a clinical adventure of chasing the last pulses. This I would put it. So the story of Takayasu is just as an introduction I'm going to give for the benefit of the students. It begins in 1908 when a Japanese ophthalmologist noticed a peculiar retinal vessels in his patients. So it was first initially detected by, please remember, by an ophthalmologist. So without introduction, we cannot proceed further. That's why I'm just going to give some introduction. It's a chronic idiopathic granulomatous large cell vasculitis. That's what the pathologist would write. Involves aorta, major branches and pulmonary arteries. It predominantly affects young women. Often diagnosed very late due to the rare occurrence. It is not very common. We do not see, except in public hospitals, in private hospitals, we do not see that very often. It is indolent. That means it's not a very, it has got a very chronic course. It's a very non-specific. Early symptoms are extremely non-specific. A lack of very specific diagnostic markers even today. Though we are trying to bring in some kind of markers. It's a worldwide distribution, but more common in Asia. A global prevalence is 3.2 to 40 cases per million. You could see that it's extremely low. Female to male ratio varies. Worldwide is very less, 12 is to 1, but China and India is 3 is to 1, which is exactly same even in our series. Age at onset globally, usually 20 to 30 years. The whole of the other Western series or other Asian countries. Indian studies, including our studies, it is 3 to 50 years. Involvement of thoracoabdominal aorta is very common in India. So it's not necessary that we should have that only the involvement of the neck vessels or the subclavian arteries. It is not really necessary. That is exactly the case what we have seen in our hospital, in my experience. So what exactly is the pathology in the Takai's arteries? The three stages. It is like any other inflammatory disease. It's an initial inflammation in the vasa vasorum and the medio-adventitial junction. Early phase, like any other inflammatory disease, it involves a mononuclear infiltrates, edema, necrosis, fragmentation of the elastic fibers, initial damage which happens. And obviously, there is a granulomatous reaction with the giant cells. The progressive changes, next stage, that the proliferation of the intima happens, causing a fibrosis. And that's the stage where the mural thrombus happens. In that particular stage, clinically, there could be a thrombotic stage with various thrombotic episodes in a particular patient. Please remember when there is an acute event happens because the thrombotic stage that is still in the early stages of the Takayasu or aortoarteritis. Neovascularization at intima media junction. Late phase, a smooth muscle loss, medial weakening causing an aneurysm, and a prominent adventitial and periadventitial fibrosis causing scarring and a stenosis. This causes a stenosis. A stenotic lesions predominantly it is the natural history is 85% and more common than the aneurysmal formation it is 15 to 20%. Overlaps are common which we have seen. This is how the vessel wall, if you an autopsy, if you do the autopsy, it's how it looks like. So bad the patient presently, only 19% of the patient clinically manifest all three stages. So there another slide which depicting what exactly causes the aneurysm, what does cause the stenosis and the thrombosis. Aneurysm, I told you the disruption of the elastin and smooth muscle, weakening of the vessel wall. In a stenotic area, if there is a deposition of the acid mucopolysaccharide and fibrosis, it causes a thickening of the intima and narrowing of the lumen. Hypercoagulable state, which is in the second stage, in a progressive stage, not in the late phase, it causes thrombosis. Please remember all these three stages. The clinico-pathological, I can say, these three stages are three different varieties of the manifestation of a Takai's arteritis or aortoarteritis. Diagnosis of Takai's arteritis. There's so many criteria. Ishikawa criteria 1888, ACR criteria, American College of Rheumatology, Dr. Sharma's criteria, EULAR criteria, that means European League of Against Rheumatism, validated in children. Sensitivity is pretty high, specificity is also quite good. Of note, these are all very classification criteria, mainly designed for research purposes. But still, please remember, one can diagnose Takay's arteritis and start the treatment even if the patient does not meet all these classification criteria. Please remember that. Provided you are convinced with the clinical, laboratory, and imaging evidence. Now we have an imaging evidence, which I'm going to come to that later. So we don't have to strictly uh, adhere to the whatever the original criteria. Of course, that gives a clue, but you don't have to adhere to that particular. You have to be very strict with those criteria. So classification of the Takayasu requires a typical angiographic abnormalities of the aorta. This is a very standard ULR criteria which is formulated. Abnormalities of the aorta and its main branch is pulmonary mandatory criteria. Of course, it has to be there. It does not say any particular arteries. It says, please remember that abnormalities of the aorta and its main branches. One of the plus one of the following: pulse deficit, BP discrepancy, bruit, hypertension, elevated acute phase reactant. So you do find any of these clinical things. So considerations when applying these are classification criteria. When applying these criteria, the absolute requirement is age less than 60. More than 60, we don't, because of the atherosclerosis will come into the picture. So obviously, we don't take that age. Evidence of vasculitis and imaging. We have imaging right now to prove or disprove that there is aortoarteritis. Additional clinical criteria like female angina, ischemic pain, electrocaudication, vascular bruit, reduced pulse, carotid artery abnormality, systolic BP difference, additional imaging criteria now. Number of affected arterial territories, one arterial territory, two arterial territories, like that, symmetric involvement. So these are all some of these imaging criteria, clinical criteria, absolute requirements. So use a cutoff of more than 5 in a total risk score. The sensitivity was 93.8 and the specificity is almost 99%. So most of our cases will have this. Please remember. So this is I think you must have gone through this standard angiographic classification in most of the books. You do find this type 1, 2, 2A, 2B, 3, 4, 4, 5, 5. So you will find you can fit into most of our cases to any of these three things. So you don't have clearly this only for the I can say just to classify which is type 1, type 2. But you please remember that any of this involvement of any of the aorta and its branches, you can make a diagnosis of the aortoarteritis. Not necessarily. I certainly do not believe in any of this classification. It is not important. Ultimately, the management is important, the treatment is important, the follow-up is important, and not trying to find out which classification does it belong. The clinical improvement, that is extremely important. Of course, here do not forget there can be involvement of the coronary arteries and the pulmonary arteries. In the below it is written combined features, and after that involvement of the coronary or pulmonary arteries is designated C plus and P plus respectively. So this is for theoretical purpose. When you want to write, you can be asked as a TSA or long-term questions. So what imaging modality to choose? This is next question. The conventional angiogram, it's a very gold standard, yes, but it's not really necessary, which is on this basis the classifications were based on it. Needed right now before interventions and the pressure management. DSA can give added information. CT angiography is the first line imaging at most of the centers in our center. It demonstrates a luminal anatomy, vessel tapering, and vessel thickening, and radiation if repeat imaging is needed. Unnecessarily, we are not subject for a follow-up CT, and it's not really needed. CT is going to give us enormous information about whether your diagnosis is right or wrong. CT will give us enormous. This is exactly you on the right hand side. You are seeing how the aorta looks like. How the aorta looks like. Very ragged, irregular aorta. You cannot miss this. And when you are clinically suspecting on the bedside, when you have a pulse discrepancy and the blood pressure is high in the upper limb, and you are doing an echo of a child or an adult, and you can scan the abdominal aorta in that area, you normally, when you see the abdominal aorta, our cells, abdominal aorta, it is very clean. You don't find any kind of an irregularity. And you start observing the aorta, it is very irregular. You can easily make a diagnosis of aortoarteritis ourselves. You don't need an ultrasonologist to make the aortoarteritis on the basis of the ultrasonology of the abdominal aorta. It's pretty easy. Even you can make, if you make some effort, you can find out at least a screening tool before you ask the radiologist to give a renal artery narrowing. We can pick up in some of the cases. So this is on the right hand side still picture. You can see how abdominal aorta looks like. So this is a classical case of aortoarteritis. So MRI is not routinely done. MRI can visualize the vessel wall directly and has the potential to detect the pathological changes of an arterial wall independent of luminal diameter. This is one positive aspects of it. However, late gadolinium enhancement cannot reliably distinguish the active inflammation from fibrosis or neovascularization. Conventional gadolinium agents distribute in extracellular space. It can be a non-specific signal. MRI has got a role in monitoring a newly diagnosed patients. Otherwise, MRI is generally we do not recommend or we do not use this MRI as a routine thing. PET scan, yes. It detects an active inflammation without any drug, like any other inflammatory disease in a newly diagnosed patients. Identify the relapses and ongoing inflammation during immunosuppression. We've got a very high sensitivity for disease activity. The heart segments, it indicates the active vessel involvement, does not provide any information about changes in the wall structure or luminal blood flow. It does not. But it definitely very sensitive for a disease activity. Choose imaging modality based on your purpose, what we are looking for. If we are already know that the diagnosis is aortoarteritis, there is no active phase, you are planning for some intervention, go for a CT. You are in doubt whether the relapse is there, you want to prove that there is an active inflammation, go for a PET scan. MRI plus minus. It's a relative indication right now. So these are all so much of ACR, the severity of the disease. Severe disease is vasculitis with a life, the classified by the ULR Society. What do you mean by severe disease? Means vasculitis with life or organ-threatening manifestations. Non-severe means vasculitis without life or organ-threatening manifestation like constitutional symptoms, headache, but it is not life-threatening. Active disease, new persistent or worsening clinical signs or symptoms attributed to giant cell arteritis or Takayasu not related to the prior damage. Remission, absence of clinical signs or symptoms attributed to active giant cell arteritis. Refractory, persistent active disease, despite appropriate course of immunosuppressive therapy. Relapse, recurrence of active disease following a period of remission. So this we should know how to classify the severity of the disease. A non-active, active is similar to the rheumatic fever. So the major relapse, coming to this ULR thing, major, what do you mean by major relapse? The clinical feature of ischemia, evidence of active aortic inflammation. Minor relapse means recurrence of the active disease that we can find out by the acute phase reactants. We do normally in our protocol, in our hospital, we do obviously ESR, CRP, we have started doing IL-6 as a routine. So recurrence of active disease, not fulfilling the criteria for a major relapse. Remission, absence of all the clinical signs and symptoms, and normalization of the ESR and CRP. We add IL-6 for this. Sustained remission, remission for at least 6 months, achievement of the individual target glucocorticoid dose. Glucocorticoid free remission means discontinued GC therapy, but could still be receiving other immunosuppressive therapy. So these are the different types. So you should know that, like our rheumatic, once again, rheumatic heart disease. So treatment of Takayasu arteritis, this is extremely important. This is what we need to understand. We know that we do not know the real etiology even today. It is someone says it's autoimmune disease. We don't know what kind of autoimmune disease. Not much of research has undergone here. We're not able to find out that. We don't know what is the gene involved. Nothing much has happened. So at least what we can do. Medical therapy is a mainstay. Please remember that. And vascular rehabilitation and intervention and long-term surveillance is also extremely important. In medical therapy, the main treatment is corticosteroids. Please remember that. Second one is conventional immunosuppressants. I will come to that. Third one is biologicals or the targeted therapy. In vascular rehabilitation and intervention, the endovascular angioplasty and stenting surgical options are there definitely even today. Bypass grafts and aneurysm repair, it is there. Long-term surveillance, clinical follow-up, and blood pressure monitoring. That's why we always have to keep one of the upper limb artery patent. Even if the patient doesn't have the symptoms, we have to keep open one of the subclavian artery because at least for the BP monitoring. Otherwise, there's no way that we can monitor the blood pressure. Drug compliance and inflammatory markers and imaging. This is comprises the long-term surveillance. So all these things are important. Nephrologist, radiologist, cardiologist, rheumatologist, psychologist, OBG, because when the childbearing age group comes, they play a very major role. Neurologist has a major role. Psychologist, because all these people, children, believe me, they undergo a lot of psychological trauma. So involvement of all these people are extremely important. Cardiac surgeons and everybody. So guideline for the management of Takayasu arteritis. Active Takayasu, not an immunosuppressive therapy. How to start? High dose daily oral glucocorticoid plus, this is a standard one, non-glucocorticoid immunosuppressive therapy, methotrexate or azathioprine plus or minus biologicals, tumor factors. I'll come to that. If there is a remission, taper daily dose of the glucocorticoid, continue other immunosuppressive agent. If there is no, consider switching to some other non-glucocorticoid. If you are giving a methotrexate, change over to the MMF or azathioprine, like that. I'll go into the more into detail later. The recommendation for patients with active or severe Takayasu who are not receiving the immunosuppressive therapy, the ACR recommends initiating the treatment with a very high dose oral corticosteroids or IV glucocorticoids followed by the high dose oral glucocorticoids only. There is no evidence that IV pulse glucocorticoids are more effective than high dose oral glucocorticoids. Please remember, so there is no evidence that Intravenous glucocorticoids have a benefit over the oral glucocorticoids. But what the real practicality, what do we follow? The first line in the ACR guideline says high dose oral glucocorticoids. Evidence, no RCT evidence favoring the IV over oral. Indication, we give in all life and organ threatening disease. What we are doing, clinical practice, we do start in our center because the child is very sick. We do come across, believe me, that at least once in a month, we do come across one or two very active, very bad cases. IV methylpred for 3 days in severe cases, then start with the oral one. Evidence, only case series, observational data, expert consensus. Indication when they are very bad, like any involvement of the CNS, renal, cortical visual compromise, and a very fulminant disease, involving their LV function is very bad. Hardly the LV is moving, there's a lot of thrombotic episodes. The rationale in the first line, oral preferred has no proven benefit. In IV pulses achieve rapid control, that's what we think. The faster suppression, then transition to oral and steroid therapy if we give the IV. That is what we are thinking. That's the rationale, but there is no real. We obviously we cannot do a randomized trial here because the disease process is like that. The guidelines favor oral therapy, but the IV pulses remain reasonable evidence informed option in fulminant catastrophic tachycardia. So, what is the optimal starting dose of prednisolone? This is a very standard one, like the prednisolone 1 milligram per kg per day, maximum 60 milligram per day. Pulse IV methylpred 0.5 to 1 gram per day for 3 days. Japanese Circulation Society's initial dose is 0.6 to 0.8, more or less same thing. So, pulse IV steroids, methylprednisolone, different ACR guidelines, high dose glucose steroids, more or less the same thing. Gradually, we need to taper down to the prednisolone 10 milligram, less than 10 milligram daily or equivalent. That should be our aim over a period of 3 to 6 months. Japanese cohort study clearly mentioned in one of the very practical point that starting a very low dose of steroid almost guarantees a very high relapse rates. That means starting less than 0.8 milligram per kg per day was linked to a very poor outcomes and significantly high relapse rates. So hit hard very early when you're starting it, start properly with a good dose, proper tolerant dose, a high dose. No point in starting a half dose or a 3/4 dose or something like that. Absolutely no use. So immunosuppressants, this is another mainstay. Guideline recommendation nowadays, according to the ACR, combine glucocorticoids with a non-glucocorticoids immunosuppressant rather than steroids alone. It minimizes the long-term steroid toxicity. This is where we stand today. Aortoarteritis should be treated along with the steroids. We need to start non-glucocorticoid immunosuppressants. Common agents, methotrexate, azathioprine, mycophenolate, leflunomide, cyclophosphamide, biologicals, TNF inhibitors. So start immunosuppressant early alongside the steroids helps to control the disease and taper glucocorticoids much faster. In a phase 1, the standard one, you know that Takayasu diagnosis, you make the diagnosis, start the GC, start DMARDs, taper GC to 15 to 20 in order to, this should be our aim. We should start tapering 2 to 3 by 2 to 3 months and then less than 10 milligram. And then target achieved, then continue taper. No, then come back to the phase 2. Then no major labs or minor labs, increase the dosage, nothing is happening, then consider the biologicals like tacrolimus and taper GC. If there is a response, then add the taper the GC, and if the target is achieved, taper the TNF inhibitor, TCZ. So otherwise, you consider the expert. If there is no response and major labs, minor labs, so we are in a big trouble in the phase 2. Really, we do not have an answer. We have to play around all these drugs, especially there in this phase 2 only we come across these biologicals. Otherwise, most of the phase 1 where we get a good response with immunosuppressants, we don't have to really worry about this. We do not have much experience with this because most of the patients do respond to this, except very few. So key message from this VLR, what happened is that initial therapy, high dose glucocorticosteroids, early combo with steroids, tapering goal, I told you, time and again, I'm repeating this because this has to be impregnated. You know, don't really need a, for each and every case to refer to the rheumatologist. We can manage ourselves. Relapse management, increase glucocorticoid slightly, major restart GC plus a consider biologic. That is the only stage in the relapse management. Hit hard with the GC and consider biologic. This EULAR algorithm emphasizes two things. Do not rely on steroids alone and have a tapering target. If relapse happens, biologics are a valid option. Conventional synthetic DMARDs, first line is steroids. GC monotherapy in Takayasu has relapse rate of 70%. No single DMARD is proven best. Methotrexate often first choice and probably is the best evidence. Randomized trials are very scarce. Recommendations are mostly based on multiple cohort and observational studies. It far from perfect. Initial remission is only up to 50%. Angiographic stabilization 80%. Relapse still occurs in 40 to 50%. Azathioprine and methotrexate have roughly similar efficacy. Methotrexate is preferred in younger patients due to more data on long-term outcome experience in the autoimmune disease. A multi-center retrospective cohort study from Europe comparative with methotrexate azathioprine, remission, relapse, and radiographic progression and drug survival similar in both. Vascular surgery rate higher with azathioprine. Methotrexate may allow better GC tapering. That's my methotrexate scores over this one. Coming to this drug, this is pooled clinical response, 77%. One study reported a angiographic stabilization of approximately 40%. Methotrexate MMF both also had substantial steroid dose reduction in observational series. Pooled mean prednisolone reduction of 63%. Relapse data heterogeneous small cohort study evidence less robust. It is a good alternative when methotrexate is contraindicated. In our center, we are coming out with the data and we are going to publish soon. This is the drug of choice in a non-glucocorticoid immunosuppressant. We are using MMF in almost all the patients, though we have not done any comparative study or randomized trial, but as an observational study, we have put them on more than 140 to 150 patients with a reasonable response. We're not happy with the methotrexate for some reason. They don't tolerate well because we need to monitor that. Here, monitoring is not so important like methotrexate, and the response is reasonably good. Only problem is an expensive drug, and the drug compliance with the poor population is not great. That is the only side effect. Otherwise, it's a good drug. So cyclophosphamide, personally, we do not have one because we need to refer them to the rheumatologist or to the oncologist, medical oncologist. I do not have a personal experience. It is all retrospective cohorts and case series. It induces remission in 60 to 80%. It is effective in a severe multivessel disease, help in reduction of the steroid requirement, achieve a long-term disease control. It is most commonly used in Takayasu. Typical regimen is 500 to 1000 milligram per square meter IV every 4 weeks, usually 6 to 12 months, then bridge over a maintenance therapy. Relapse rate is 15%. So DMARDs, biological DMARDs in Takayasu, in patients with refractory to treatment with glucocorticoid, we conditionally recommend adding a TNF alpha inhibitor. Its a level of evidence is very low. EULAR says TNF inhibitors can be considered in case of relapsing or refractory disease despite conventional disease modifying antirheumatic therapy or drug therapy is once again low. So it does EULAR 2018 says does not preferentially recommend TNF inhibitor or the tocilizumab, acknowledge just low quality evidence. Both are acceptable second line biologicals. So conditionally recommend you adding a TNF alpha inhibitor or TCZ, more clinical experience and observation data. So TCZ means tocilizumab, that all of us know that it's a IL-6 receptor inhibitor, a receptor. TNF inhibitor, infliximab is widely used in some of the other conditions, like we do use that in a Kawasaki disease, widely used by the pediatricians and pediatric cardiology group, the TNF alpha factor. Rituximab or other biologicals, we don't have much experience of usage in India in aortoarteritis. The one is expensive, another is monitoring, and not much of, because we don't have so much of caseload. While steroid and CMOD remain the backbone, some patients relapse or remain refractory despite the second line therapy. So conditionally recommend adding TNF and alpha inhibitor over the adding tocilizumab. More clinical data and real world experience with TNF alpha inhibitors. Tocilizumab lower the ESR-CRP may complicate activity monitoring. So both can be effective in refractory and relapsing. That's the conclusion in majority of the editorial articles. As more randomized control data, although it is underpowered, demonstrated trend towards the longer time to relapse, targeted IL-6 inhibition possibly aligns more with the pathophysiology. So these are all evidence. A very, very small cohort of inhibits. What exactly this says is the what is which is what, but ultimately the summary is that nothing is better than the other. So these are all various studies. So bottom line is both TNF inhibitor and tocilizumab are effective in refractory. No strong evidence, same thing, and depends on the choice depends on the patient profile, comorbidity, expensive, risk of recurrence has been reported. So what is the now coming to the endovascular therapy and reconstructive surgery? I finished the medical part of it. And coming to the endovascular therapy and reconstructive surgery indication, these are all the ULR criteria. You don't have to strictly adhere to this criteria many times because we need to tailor our own Indian setting. We have to see a lot of things. For example, it says that if the patient is asymptomatic, doesn't have a claudication, you don't have to revascularize. But if both the upper limbs are involved, both subclavians are involved, where do you measure the blood pressure? Patient is asymptomatic, but how do you, so that is why it is mandated to keep at least one upper limb vessel flowing. So like that, you don't have to very strictly. That's what I am trying to tell you is that. So the guidelines, what it says, the indication is persistent vascular lesion despite medical therapy, symptomatic, limb stenosis causing claudication or high risk lesions, rapidly enlarging aortic aneurysm. That means surgically has to be treated. If it is rapidly enlarging surgical, obviously it going to rupture. Preferably perform procedures during a stable disease, obviously. Active disease surgery and intervention carries a very high complication risk and lower the potency. Emergency exceptions, of course, if there is a limb is at risk because of thrombotic problem, we need to intervene. The stroke, we need to intervene. Aneurysm dissection, obviously, the surgeon has to be called for it. Or we may have to endovascular intervention if possible, feasible. So overall theme, avoid surgery or intervention unless absolutely indicated. It is reserved for life, organ or limb-threatening situations. Mere limb claudication without function compromise, even in the presence of significant strain, is not an indication for intervention. I think we have to add it is a relative, I can say. We have to tailor or titrate, customize this particular indication, as I mentioned in some indications. Prefer medical management, particularly immunosuppression to control inflammation and prevent worsening of ischemia. Surgery intervention is very high risk during active disease. That definite. There's no question about it. So it should be ideally delayed until the disease is quiescent. So I'll show you some of the case summaries, cases. A 15-year-old female presented with class 3 symptoms being treated as a myocarditis elsewhere, either DCM, blood pressure upper limb 160 by 100. Please remember the postgraduates, any DCM comes to you at even your duty hours, the related cardiomyopathy, LV function at 25 to 30%, you find the blood pressure is more than 140 by 90 or something like that. Diastolic pressure is more than 90, systolic pressure 140 or something like that. They cannot have anything. I mean, most of the times you land up in having the diagnosis of some kind of aortoarteritis because the cardiac index cannot be generate so much unless there is a problem with aorta or renal artery stenosis. They have to be hypertensive heart disease. So please palpate all the pulses, auscultate the abdominal bruit, auscultate the renal bruit. You may be right in majority of the cases. So symptoms and signs of heart failure, all pulses felt. That does not mean that the child cannot have aortoarteritis. Abdominal bruit audible. So see, echo, severe LV dysfunction, CT aortogram, we did that left renal artery, left kidney size is preserved, elevated inflammatory markers. So this is how the LV function must be around 25, 30%. So you can see some thrombus, LV thrombus also. So we knew that this is aortoarteritis by ultrasonography of the abdomen, aorta. So we know that it is definitely renal bruit was there, CT was done. You see the left renal artery. Started on the usual medicines like I told you that we started MMF for MTX many times. For some reason, we have started 2 drugs. It's not really necessary. Supportive medication symptomatically improved. LV clot burden reduced at 3 months. We did not intervene this, though LV was down. Marginal improvement in LV function. Renal artery rehabilitated after 3 months. And many times, the aortoarteritis can involve the myocardium along with the hypertensive heart disease, which can knock out the LV. It can involve the myocardium. This is very commonly we have seen. Though we have rehabilitated their abdominal aorta, we have rehabilitated this renal arteries, LV will never improve. For some reason, it also causes myocarditis. So this is our personal observation. So this is second case, another case of Takayasu, non-compliant with medications, severe headache, vomiting dyspnea, lost a follow-up for 2 years. We put her on medications, low drug compliance with BPO stoned by 140, hypertension, exerted hypertension. This is a very common thing, bilateral renal artery stenosis in these children. So we try to revascularize at the same sitting, but we don't stent it unless there is a bad dissection. Never stent this, even though they're not in children, we do not stent it. Of course, in adults, you can stent it. Preferably, Dr. George Joseph stents with a covered stent, which is right because you're eliminating the problem there. So we do not stent them by and large, but we are forced to stent many times because the dissection is common or a rule many times. So this is a 15-year-old girl, hypertensive emergency, stabilized, severe elevation, continuous flow in the. You see the aorta, how ragged there. So this is the aorta, how it looks like. So dissection is a rule. If you, even in the active, non-active phase, we stent that many times because of the dissection. We use, there's no particular usage of stents, but if there no arteries are involved, best is to use the covered stents. But many times it involves the most of the abdominal vessels, so we are so scared, we cannot use the covered stent because it involves a lot of abdominal vessels, so we cannot use the covered stents. We can use a very easy to use the self-expanding stent because they go through the smaller sheets. So this is 8-year-old myocarditis, similar, same. We want, this is an acute phase. We sent her with some medicines. We came back with after 1 week, status epilepticus, hypertensive encephalopathy. So it tells us that the guidelines say we should not intervene, but she comes back with hypertensive emergency. What to do? So we were forced to intervene. Ventilated, NTG taken for intervention. Balloon dilatation of the abdominal aorta, everything. So this is one case where we need to intervene in the acute phase. So this is a 4-year-old boy. Just to emphasize that aortoarteritis does not into the only the old age or in the teenage. Oh, sorry, it's not playing, doesn't matter. So this is a 4-year-old boy had aortoarteritis. So we had to rehabilitate the whole of the aorta. This is 13-year-old lady, 6 months dyspnea. So this is also not playing. Okay. She had a coronary involvement. So osteal stenosis that she went for surgery. Ultimately, she could not make it because she presented very late. So this is one case we had aortoarteritis plus pulmonary arteries. This involves the ostium of the bilateral arteries. Of course, she had some other features of abdominal aorta. Along with that, she had a pulmonary artery. So always try to look for pulmonary arteries. Do not forget the pulmonary arteries. So we stented that because otherwise the recoiling will happen. So after doing the medical therapy, endovascular therapy, what to do next? Regular BP controlling and target evaluation, prevention of osteoporosis. Someone is on high dose steroids, some prophylaxis is pneumocystis, cerevisiae, all this because these people are on immunosuppressants. Regular immunizations is very important. Antiplatelet not routinely recommended, but we need to give that because we are in a different setting. It is because if we put on, we do not know etiology first of all. We do not know what is the mechanism. So antiplatelet therapy, it is single antiplatelet we put them on when we are doing the renal angioplasty. Large vessel like abdominal aorta may not be necessary, but it is not, it is definitely indicated in the renal artery intervention. Used for patients at a higher risk for ischemic event. Low level of evidence, that's what the evidence says. Anticoagulation, yes, if there is a thrombus, as I told you in my first case, we need to give anticoagulation. PTA was a surgical. PCA and PTA, there's a intervention, percutaneous intervention. It's a short segment disease. It's indicated non-scar, non-extensively fibrous segments. Endovascular surgery with bypass is still, it's a indicated where you cannot revascularize the bilateral renal arteries. We need to refer them for surgery, which is not impossible. The surgeons do a good job because we need to protect the kidneys. Restenosis is less likely compared to our interventions. Operate with pre and post steroid cover. We need to give them steroid cover during surgery or obtain a sample for histopathology if possible. Be cautious in kids. Operating a child and inserting graft that the child outgrows will need more surgeries. Endovascular balloon angioplasty versus stenting Takayasu. Meta-analysis of renal artery balloon versus PTA. Clearly, the summary says balloon is better than stenting. If dissection occurs, then stent. Otherwise, do not stent it. A clinical laboratory and laboratory monitoring in Takayasu, serum inflammatory markers should be added to the clinical monitoring. It is mandatory. Rising markers alone do not escalate immunosuppression. Instead, observe clinically. Just because the markers are increasing, the clinical patient is okay. You don't try to escalate immunosuppression. Increased markers are very non-specific. Reassess with more frequent clinical imaging checks. That is the area where the imaging at times we may have to repeat either the CT or if available, a PET scan comes into the role in a follow time. They prefer non-invasive imaging over a catheter. Obviously, we do not do that unless we are planning any kind of a intervention therapy. A regular scheduled imaging recommended in addition to the clinical follow-up. Frequency, it is individualized. The multiple disease activity scoring systems are available. We use ITAS on regular basis. So these are all the different scores available most of the times. So it's not very difficult to obtain this. So lesson learned and myths busted. Age and sex, no bar for involvement. The standard teaching, standard literature, the globally, it is older age group in the third decade or something. No, we do see younger age, very common in less than 10 years in our public hospital setups. Women are common, yes, but we do quite significant number of boys. We do see active disease may need urgent intervention and life may be saving. It is one of the cases I can say 10 to 15% of our interventions are done in the active stage because we need to save them. In fact, we have done as an emergency even at nights. No, the drug for control of inflammation and disease progression. I've enumerated, probably I bored you with a lot of repetition of the drugs. But unfortunately, there is no the drug for control of inflammation and disease progression. At least if you know some of these drugs. Steroids, that is prednisolone, the very cheap drug. It's a good drug. And MMF or methotrexate, azathioprine, cyclophosphamide, these are some of the drugs. Recurrences are common, neither balloon or stenting is superior. Highly thrombogenic state, especially in the active phase. Please do not forget it. Look for the clots, both in the abdominal aorta, LV, everywhere. A rapidly progressive severe intimal hyperplasia and thickening. This is one of the problems. A high index of suspicion is very crucial. It masquerades as myocarditis. As I told you, just few minutes of clinical examination, the blood pressure and pulse examination, you cannot miss this particular diagnosis. Rheumatic heart disease is another one. A severe MR can be just we have our presidents have missed that labeled as it's a rheumatic heart disease, but next morning we come and proper clinical examination has revealed that it is aortoarteritis. Essential hypertension labeled so many times. If we are not examined properly, we label them as essential hypertension. This could really make some control with the management of aortoarteritis. Or we miss the bus. Need long-term anti-inflammatory and immunosuppressive drugs. The counseling, especially with these parents or the relatives, is extremely important. Long duration of follow-up needs marriage and pregnancy counseling, strong psychosocial support. These clinical features a tabular column of Mexico, India, and South Africa. This is how it looks like in the various studies. But in our center, we have more than 150. This is almost a 3-4 month old data, which I can see that we have more than 200 patients, possibly. They have more than 15-20% mortality. The hypertension is present as a rule in everybody and significant mortality. And we have not been able to achieve lot of losing their follow-ups. So acute, to summarize, I can say the acute presentation, stabilized supportive therapy, pulse steroid, CT imaging to define minimal intervention in acute state, discharge and high dose oral steroids with MMF. That's what we do. Our protocol, chronic stage, taper and optimize steroids, add MMF plus or minus MTX and methotrexate. A minimal long-term steroid use, clinical lab monitoring. This is standard what we do. Individualized imaging, follow-up, individualized intervention. Relapse, escalate immunosuppression, increase steroid dose, severe relapse, country repeat pulse therapy. Well, as we don't have institutional experience yet, this is my honest experience. Rheumatology consultation on case-to-case basis. Otherwise, we do not refer to the rheumatologist unless we are in deep trouble. We do manage ourselves. We have our colleagues; they do a good job. To conclude, unknown etiology makes the management extremely difficult. Clinical suspicion and early diagnosis may help the reduction in target organ damage. No clear-cut guidelines even till today for the medical management. Worse than a malignant disease, at least majority of the malignant diseases, we have the treatment in the form of, and they can have a remission here, no remission. On a positive note, some immunosuppressants and endovascular treatment have a ray of hope for some patients at least. Thank you very much.
So thank you for a very excellent presentation. We hand over to the chairpersons now, Sharma sir and Vaideshwar sir.
Pradeep is there, no? Yeah, he's there.
Yeah, let Pradeep begin. He will throw some insights.
Dr. Pradeep, you're muted.
Yeah. Yes. Thank you very much. I really enjoyed the lecture. I just want to make a few points. Like, I'm very happy to see that Sir has put erythrocyte sedimentation rate as one of the important investigations for, monitoring the disease. Nowadays, no one looks at ESR with those good eyes, and they always think that it is sort of relegated to the, what shall I say, the most lowly type of investigation. But I feel that if you do a scrupulously well done ESR and high sensitivity CRP is as good as doing, IL-6. That is point number one. Then I saw that the age was written as, less than 60 years of age. But very often, what happens, Takayasu and maybe even the other type of aortitis, they predispose to development of aortic atherosclerosis. So if you have atherosclerosis at a odd site, for example, if I have a 68 years old male and who has predominant atherosclerosis in the thoracic aorta, it will point more to a aortitic process which has predisposed to secondary atherosclerosis. The third important point is that when you look at the pathology of Takayasu, what is extremely striking is a significant amount of adventitial and periadventitial fibrosis, which is not seen in any other aortitic syndrome. So that also is extremely important. And I mean, there have been talks about, myocarditis in cases of Takayasu, but unfortunately, in most of our autopsy material, we have not seen myocarditis, maybe at the most, say, almost like 5%. And most of that cardiac dysfunction was produced by subtle amount of coronary ostial stenosis. And when we have Takayasu with a predominant involvement of the non-aortic segments, there are always some telltale inflammation is always present in the aorta. So I would say that Takayasu has 100% involvement of the aorta. It may be subtle, it may be subclinical, or it can be, clinically overt. And the other thing, I feel that the history is rather slightly distorted. Like if you take Takayasu, he showed that there was some abnormality, what he called as coronary anastomosis of the central retinal artery. But unfortunately, that time he did not describe the loss of pulsations. And in fact, in the same year, that is in the 1905 meeting, it was Professors Onishi and Kagoshima. They also reported a similar retinal changes, and they reported the absent bilateral and left radial artery pulsations. So somehow it got the name Takayasu came because I don't know for what reason. And actually speaking, it was described in 1761 by Morgagni in a 40-year-old woman patient. So the history, when you look at the history of Takayasu, it goes back to almost 200 years, not necessarily 1905. Thank you.
Thank you, sir. See, the myocarditis, I completely agree with you. Obviously, when the whole pathology is revolves around the aorta and involvement of the arteries, obviously myocardium cannot get involved. But what we see, what I fail to understand in our clinical day-to-day practice is we treat the patient as a whole. I'm as a clinician, I can say we treat their hypertension, we relieve their obstruction, we do the renal artery, everything we do that. But a lot of children, I can say in our series, about more than we have more than 180 or 200 children. In some children, they just do not improve. LV dysfunction will not improve. So
Right.
if you really see their history, in the sense the duration of the history, their duration of the illness, it doesn't go more than 2 3 months. What makes them so bad? For example, even nowadays, even the DCMs, if good medications with all available dilated cardiomyopathy, they do improve. But here, they just don't improve. They do die. I don't know really because we have not got the evidence by the autopsy. We don't. We are not very fortunate what to do. But I completely agree with you. I cannot make that it involves the myocardium. No way. No way.
Yes.
So
Because
the
it's
myocardium
somewhere.
is secondary to the hypertension and this. Is
No,
that
I
correct?
know, but we relieve the obstruction. We relieve the obstruction. For example, you take a case of aortic coarctation of aorta. You
Mhm.
Hmm.
relieve the obstruction. If there is a LV dysfunction, there will be at least partial improvement of
Yes.
the aorta, LV. Aortic stenosis, you relieve the obstruction. We do see improvement unless there is a terminal phase. But in a child of a 10-year or a 12-year-old, history only dates back only 60 days. They come with the LV dysfunction. You treat everything, but LV doesn't improve.
Right.
That is my problem.
Have you all gone, have beyond echocardiography and demonstrated the LV dysfunction by other imaging techniques
Yes,
like,
we have
say,
done
MRI
MRI.
or
MRI.
something?
We have done MRI. We have MRI, they'll say just myocardial involvement. They say myocarditis. They say just myocarditis. Whatever we write, they'll
Okay.
write. That's all.
Hmm.
No, biopsy data is
No,
cardiac
no, sir. We have not
biopsy.
done well. See, these children are
Yeah,
very sick. I think they won't survive
I
that.
know it will be difficult to.
Very difficult. Very difficult.
Right. Just one or two therapeutic points I wanted to ask you. In, where we do see a lot of DCM in children. Now, renal artery stenosis is very common in aortoarteritis. Do you start these patients on any of the drugs which are RAS blockers, or you follow some protocol to first rule out renal artery stenosis?
No, no. We rule out renal artery stenosis, sir. That is a must.
That's
Uh,
a must.
Unless we have ruled out renal arteries, okay, there is no involvement of the renal arteries. If aorta is taken care of by doing the stenting or the balloon dilatation of the aorta, absolutely there is no involvement of the renal arteries. Then we put them on the newer drugs like RNA and all. We put them on to see that whether
Right.
the LV improves or this dapagliflozin and all. We do start that. We do start that. We just follow the standard heart failure management.
Right.
If there is a renal artery involvement, we don't start that.
Right. And just asking a point about the balloon dilatation, these lesions are sometimes extremely non-compliant to balloon dilatation.
Absolutely,
So do
yes.
you use cutting balloon?
Yeah, we have used cutting balloons. So there are two types. We come across two types, sir. One in the relatively the early phase or a active phase, you don't need a cutting balloon. They yield very easily. The problem of dissection and a thrombus formation. We have done that quite often, many times. very low balloon, low profile balloons, we use that. The cutting balloon we have used in the chronic phase. We have used in a slightly healed phase or a completely burnt out phase, we use cutting balloons. Even in cutting balloons, when you used also, we get a suboptimal result only. Then we'll be forced to put two wires, buddy wires, all those things we do it. Slightly older children, we have no choice that we need to put a stent with high pressure dilatation and all that. Yeah.
Is there a
Yeah.
group of patients where the natural history is quite favorable? Because there was
Very few, sir, very few. Yes,
some
there are few.
articles in
Yeah, there
earlier
are few.
years.
Yeah, there are few. There are few. Even our children, our follow-ups, there's some children they're doing quite well. Especially they are adhering to these drugs, especially the steroids and MMF. And not much of whole aorta is not involved. Only a patchy aorta is involved. Only one renal artery is involved. Especially the only subclavian artery is involved. Not much of very drastic involvement of all the aorta. They are doing well. They are doing well. They are about 20
Jagannath,
30. Yeah.
Jagannath, is it right treatment if we start steroids with MMF in the initial treatment?
Yes, we that's our protocol. All cases we start GC
And not
plus
just start steroid first and then
no,
add
no, no,
MMF.
that is wrong. That is wrong. No, we have to start GC plus MMF straight away. It is like we were taught when pulmonary hypertension is there. What we were doing first? We were doing only sildenafil. No, now the things have changed. You have to start both. You have to start both sildenafil plus ambrisentan or whatever. Like that. Here also we have changed over to GC plus MMF. MMF means what? Immunosuppressants. Yeah.
And at what stage of disease process it can be reversible? Because many times we
Reversible.
don't know at what stage we are really starting the drug.
No, no, completely. We know that everything is okay. They are doing extremely well. The clinically we follow for 6 months or 1 year. I think I do not find a single case that at least we continue the steroids at least 5 milligram per day in a very long run. I don't think we have stopped because we are scared.
I have one
Doc-
question regarding practical management. Sometimes in older adult patients, we often come with these burnt out or severe cases in which the thoracoabdominal aorta is involved and both the upper limb arteries are involved. And these patients almost universally have hypertension. So
Yes.
how do we monitor the blood pressure and adequacy of BP control in them? It becomes very challenging.
Yes, very challenging. That's a big problem. That's why I think as far as possible, we have to keep one artery, upper limb artery, you have to patent. If you really, I advise you in those cases, you image that artery, upper limb artery. We have done that also. One or two cases in adults, I have recommended that. At least God. You do that if the image the artery, subclavian artery, axillary, you do the carotid bypass. If the carotid artery is fine, do the carotid bypass. Because the recording of the blood pressure is extremely important, no?
Yeah.
As they go,
Absolutely.
they don't
Absolutely.
see. According to me, the blood pressure is more dangerous than diabetes. They can die of intracardiac, intracerebral hemorrhage.
So we are in a
In
big
Yeah.
dilemma, sir, in these patients.
pardon?
We are in a big
Yeah,
dilemma how to
yeah.
monitor blood pressure.
Ask the surgeon to do the bypass. If the
Dr.
carotid is fine.
Ranganathan, can I ask a question for you? Dr. Ajit
Yeah,
Desai here. Two
yeah.
questions. In fact, is the giant cell arteritis, which is a localized disease, is it a subset of Takayasu's or is it a totally different one?
No, it is some kind of a subset, sir. I think there is not much of thing. It's no clarity on that. Terminologies. Yeah.
Okay. The other thing is we had the fortune of treating two of the aortoarteritis with the endovascular therapy for the abdominal aorta. In one case, is the renal arteries could give away very easily. But in the second case, in spite of using the cutting balloon and this thing, the renal arteries did not give away, as Dr. Sharma said, So it becomes very difficult because you treated the aorta and the aneurysm, but the renal artery stenosis continued to be there, in these patients.
So what is the size of the renal artery, sir? What are
The
the
renal
size?
artery, the renal artery looked to be quite small on the left side. It was almost about 3 to 4 millimeter, but the right side was quite good. It's almost about 5 to 6, but just did not give away.
So 6 millimeter one did not yield at all, you
Not
think?
at all, not at all. In spite of putting in the cutting balloon also.
Cutting
So
balloon also.
yeah, yeah, yeah.
So
So
what Dr. George Joseph does is that I don't have much experience of using a covered stent. What he
yeah,
does is he uses a covered stent. He will
okay,
go very high pressure. He is not scared of rupture.
fine, okay.
Yeah, yeah.
So one more challenging subset is patients, females in their 20s and 30s who are thinking of pregnancy. So how do we holistically approach, because there are going to be many issues in pregnancy for them?
Yeah, that's a very problem that we face. Definitely, one is counseling. We have to do that, and we have to keep that aorta properly. For that, aorta has to be proper because aorta is the one which is very, very important for them. Extremely important. So aorta, renal arteries, you have to keep patent. So that is why we need to revascularize as far as possible, keep the aorta. And generally, the aortic restenosis at that age is not very common, not very common. We can maintain, you can keep on redilating. No problem, no problem, no problem.
Right.
Restenosis rate is not very high, not very high.
Right.
You can keep on dilating, you can keep on dilating.
Right.
Okay.
Yeah, is pregnancy contraindicated in this female?
No, 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 no. We have many girls, we have got them delivered. No problem, no problem.
Does the disease process accelerate during pregnancy?
No, 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 not at all. Nothing to do with the pregnancy.
Okay. Great.
Chandra, are there any questions from the students? Can you share with us? Because they are typing in the chat box. We have more, by the way, we have more than 400 plus attendance, which is quite a record for us for our PG track. So,
So far, no question. I'll inform you.
right. Anybody from the panelists, anybody else has any questions? Any points for discussion? Any senior faculty logged in?
No.
I think,
Thank you.
yeah.
All right. So, sir, Dr. Satyavan Sharma and Dr. Pradeep Vaidya, sir, any more comments or something, or shall we conclude?
I think we can conclude. There has been a very good discussion.
Excellent.
Yeah.
Yes. Thank you.
Okay.
Excellent
So-
presentation. Fantastic.
So, as a secretary for the Mumbai CSI branch, it's my pleasant duty to offer a vote of thanks for this fantastic meeting. And I think, firstly, we would like to thank Professor Dr. Jayaranganathan for accepting our invitation and giving such a fantastic lecture, so comprehensive, so precise, yet very simple and clear, made us understand a lot of things, some things which we had forgotten, what we had learned as students, and for the young students, I think it must have been really fantastic. I would like to thank our expert panel, Professor Satyavan Sharma and Professor Pradeep Vedeshwar. Both of whom have a fantastic, and I think the one of the vastest experience of clinical and pathological, experience in dealing with aortoarteritis. I think so. We are very fortunate that both of them were here with us and guided us through this with their expert comments and insights. I would like to thank Dr. G.R. Kane, our president, for conceiving this whole meeting, for this fantastic meeting, and Milind Phadke in particular, and also Snehal Kulkarni and Dheeraj Kumar for making the program and coordinating this whole thing. Milind, I think you did a fantastic job, and so did Snehal. Dheeraj is not here because it's his birthday today. I wish to thank the sponsors, Sun Pharma, the makers of Rosuvas and Chakurice, for supporting the meeting. All our CSI members, executive committee members, as well as our general members, for always being very supportive for our programs and for our academic initiatives, and all the delegates who have attended this fantastic meeting together. Thank you, everybody, for being here. And I would ask Dr. Kane, our president, to give his concluding remarks. Thank you.
Yeah. So, as everybody has said, it's a very, very nice meeting. We learned a lot because there's always things to learn from people who work deeply into this and who have a larger experience. And this being not a very common entity, so very few people have a very large experience. And one of them is Professor Jai Rangnath. So thank you very much, Dr. Jai Rangnath, and thank you, Dr. Satyavan Sharma and Vaideshwar, and all those who have attended. So this PG series of ours is going to be a continuous effort on our part, and every alternate last Wednesday of the month, we are planning to have one talk. So the next will be in November, last Wednesday of the month. Is that correct, Milind?
Yeah. And
Milind,
looking at this response, we are very enthused.
Yeah.
So 400 plus attendees.
Milind is in the forefront of pushing this agenda, and we are very happy that that he takes a lot of efforts in this. So thank you very much. Thanks, Ajit.
Thank you.
Yeah. And yeah, so let's conclude. All good things have to end. Thank you. Thank you so much.
Thank
everybody.
you.
sir.
Good
Thanks,
night, everybody.
everybody.
Bye.
Good night.
Thank
Good
you.
night.
Good night.
Thank you.
Thank you, sir. Thank you, Milind.
Thank you very much, sir. Good night.
Thank you, Milind. Thank you. Yeah.
Bye-bye. Thank you.
Thank you. Good night.
Thanks, sir.
Thank you. Good night.
Thank you, Snehal. Thank you, sir. Thank you, Sharma. Yeah.
कितना हो गया स्कोर?
राहुल
जी सर।
हाँ ये हम बाद में अपलोड कर देंगे ना, ये डाउनलोड कर क्या बाद में आप भेजोगे मुझे?
वैसे तो मिल जाएगा लिंक।